Being a physical therapist, this is a section I quite enjoy. However, it's crucial dentists and anyone else who refers or has the potential to refer patients to a physical therapist understand what type of treatment we can provide, just as it's vital that physical therapists understand the type of treatment dentists can provide. Physical therapy treatments can include soft tissue mobilization, extra and intraorally, cervical spine manipulation, TMJ joint manipulation, dry needling, exercise, and education. Upper cervical thrust manipulation is vital for treating TMD. Corum in 2018 published research that compared an upper cervical rotatory thrust technique combined with neck exercises to a sham thrust manipulation and exercise or education alone. Neck exercises included the range of motion, stretching, and strengthening of the cervical spine. Thrust manipulation combined with exercise was more effective than the education alone group for all the outcomes measured, including pressure pain threshold, maximal mouth opening, and the physical and mental components of short form 36. Further, the thrust manipulation group also significantly outperformed the sham manipulation group on pressure pain threshold. Picture here is just one way that you can provide the rotatory upper cervical thrust manipulation. In the three articles referenced here, an occipital atlantal thrust manipulation was used, instead of an atlantoaxial manipulation as performed in the previous slide. Research here did not look at long-term outcomes, but on immediate outcomes. Results found were decreased pressure pain threshold, increased maximal mouth opening, and normalized EMG activity. Here's another slide on the importance of treating the cervical spine for TMD. In 2016, Calixatre et al. Studied patients with TMJ diagnoses of myalgia or myalgia combined with joint involvement of the TMJ. They used upper cervical flexion mobilization and C5 posterior anterior non-thrust manipulation, craniocervical flexor stabilization exercises, and neck stretching. The session lasted for 35 minutes, and 10 sessions were performed over the course of 5 weeks. The 12 subjects that were used in this trial demonstrated improvements in pain-free maximal mouth opening, self-reported pain, and mandibular functionality. Dry needling is an intervention that I've seen to be quite beneficial anecdotally that is also supported by research. In one trial by Gonzalez Perez, dry needling using a 40 millimeter needle that is put into the lateral pterygoid by inserting it just anterior to the condylar process was compared with taking methocarbamol, which is a muscle relaxer, and paracetamol, which is acetaminophen. Dry needling was performed 3 times over the course of 3 weeks, and the group taking medication took the 2 tablets every 6 hours for 3 weeks. The results demonstrated that dry needling was more efficacious in reducing pain and improving maximum mouth opening, laterality, and protrusion movements compared with the medication treatment. One of the best studies with treating TMD conservatively was done by a chiropractor in Australia working on his PhD. Subjects had daily jaw pain and were between 18 and 50 years old. There were 3 groups, with one being a no treatment group. The intervention for one group included only intraoral soft tissue mobilization, while another group also included education and 2 TMJ specific exercises that could be performed at home. Both showed significant improvements at 6 months and 1 year compared to the no treatment group, with the one that included exercise and education even better than the manual therapy only group. In a 2001 study that was published by 2 physiatrists in Europe that provided multimodal treatments to 20 patients with radiologic findings of TMJ osteoarthritis and jaw pain for at least 3 months. While specifics of treatment isn't detailed, it is clear that it included soft tissue mobilization, TMJ joint manual therapy, active range of motion, active assistive range of motion, and passive range of motion, progressive relaxation, and postural correction. It says the treatments were provided by a physical therapist who is specifically trained in craniomandibular dysfunction according to the principles described by Booman. There is a very in-depth book that can be found on Amazon called TMJ Disorders in Oral Facial Pain, the Role of Dentistry in a Multidisciplinary Diagnostic Approach. Make sure to get the translated version, and unfortunately it is definitely on the pricier end. Anyway, 85% of patients significantly improved in regards to pain and maximal mouth opening and didn't require further treatment. Those that didn't improve were fitted for appliances by dentists. In the articles by Taylor and Carmelli referenced here, joint mobilization was a primary intervention. Results were Results were normalized EMG activity in the masseter, decreased pain, and improved maximal mouth opening. Calixtra et al. Published a systematic review of RCTs in 2015. I'll go into more specifics, but overall what they found is that manual therapy works for patients with TMD symptoms. Soft tissue mobilization to the muscles of mastication is effective even when compared to toxin botulinum injections. Upper cervical spine thrust manipulation and non-thrust manipulation is effective. The final conclusion was that there is moderate to high evidence that manual therapy techniques protocols are effective. In the systematic review by Olivio et al., there were 12 studies that evaluated, you can see the details of in Table 2 if you go to that study. 4 of the studies found no relationship between head and or cervical posture and TMD, while 8 of the studies found at least some correlation. While this is far from conclusive or a cause and effect relationship, it indicates that posture warrants at least an evaluation, and intervention may be indicated as part of the treatment plan. However, I've found nothing evaluating the effectiveness of interventions treating only posture and the effect it has on TMD symptoms. So after the review of several research articles evaluating physical therapist interventions, I'll review them all here. Don't make it more complicated than it needs to be. It is often best to start with the spine because many people see improvements when the spine is treated, and most therapists have treated more necks than they have jaws. Then progress to the jaw. Perform soft tissue mobilization to the jaw, to the muscles of mastication, which is basically massage extraorally the temporalis, masseter, sternocleidomastoid, upper traps, and massage intraorally the pterygoids and sphenopalatine ganglion. Perform TMJ mobilization, focusing on distraction. If the presentation is primarily arthritis, then it'll feel like other arthritic joints we treat. If it's a disc displacement issue, then it can still be beneficial, but will feel a little bit different to you during the mobilization. If the person has a deviation or a deflection, it may be helpful to mobilize opposite of the direction of deviation or deflection. Then give exercises that complement your manual therapy techniques. For arthritic joints, exercise in all directions is helpful. For all conditions, resistance away from the side of deviation or deflection is helpful and often more comfortable. Plus, a review of posture will help to improve. Plus, a review of posture and helping to improve posture may be helpful as well.